Suman is going to take care of the entire in-depth evaluation of this. I will just briefly run through it. It basically describes the echogenicity, margins, classification, and shape. So it helps us to characterize this nodule and predict the risk of the nodule being malignant. And it also helps us to guide from which area of the nodule you need to take the biopsy or you should be biopsying. So this has been defined ATI criteria of thyroid nodules which are suspicious, which are benign looking or which needs attention. So if it is cystic, a thyroid nodule is cystic, you probably are dealing with a benign condition, probably you may end your evaluation at that point if the patient is not apprehensive. As you go in the difference in the characteristics, spongiform is still under benign condition, but the moment it starts giving a solid component, then probably your level of investigation enters. So the solid cystic, solid with irregular margins, and solid with more irregular, regular and irregular margins, they are the areas where you probably would like to intervene and investigate. And they kind of grade it, give some criteria on the basis of this, all the parameters, and they score it, and that is known as direct scoring. So they get 1, 2, 3, 4, 5 or 6, more than 6, more than 4 to 5 or something like that. So on the basis of this, they characterize the thyroid nodule. Say our thyroid nodule was thyroid 4. Now it meets the criteria. So here again ATS defined which nodule should be FNSA, which category of nodule should be FNSA. So they have given certain criteria based on the thyroid's grading and the size of the nodule, correlating it, and the history of the patient. So this is the defined criteria, and say our patient had a thyroid nodule of 1.5 centimeter with a thyroid score, so it becomes an eligible candidate for going with the further step of evaluating the histology of it. So we did ultrasound guided FNSE, and the result comes as Bethesda 3 or Bethesda 4. Now what? Okay, so then this is the Bethesda, madam is going to take care of the entire Bethesda system of thyroid reporting. So these systems are basically to make a uniform evaluation of the findings of the pathologist so that it can be communicated grossly, like it is T and M staging. Anybody says T1, T2, M0, you understand what do you mean by T1, T2, M0. Similarly, if Bethesda 1, 2, 3, 4, 5 or 6, somebody somewhere else will also understand what we are talking about the thyroid nodule. So it's a uniform system, and 1, 2, 3, 4, 5, 6. So lower bottom 4, 5 and 6 they fall in terms of malignant lesions, highly suspicious or suspicious. 3, 4 are the intermediate. 2 is benign and 1 is non-diagnostic, so you might have to repeat or you can follow up the patient. So on the basis of this, there are recommendations of how to go further. Okay. So now if there is Bethesda 3 or 4, there is further evaluation that is possible whether you want this patient, because there is no clarity. The pathologists are not able to clearly define whether this nodule is benign or malignant, but there is a probability of this being a malignant also. And the patient is really apprehensive, very high profile, and you want to further find out whether this patient needs treatment or not. If you do the treatment, there is some complication, the patient might come and sue you. And if you don't do and you say you leave behind, if there turns out to be malignancy, you are again in a problem. So how do you answer this question? So again, our dear pathologists, they come in, help us here. So there is a molecular testing of this FNSE which can be done. I'm not going to go in detail of this, probably madam will try to cover, but there is a rule in and rule out test where the NGS, that is the genetic evaluation of the thyroid nodule, is done. There are panels which have been defined, and there is a sequence of panels that being as a group. So they help us to rule out malignancy or rule in benign. And then similarly, you have this test done, different this thing. And so let us see, our nodule was, one molecular test was benign. So then you can take an option or call of doing observation versus doing, if at all cosmetic reason, you do hemithyroidectomy. So this is one way of starting the evaluation. Now say second case, a 55-year-old female with 2.5 centimeter nodule, ultrasound was thyroid, 5 irregular, microcalcification, FNSE is Bethesda 4. So we are dealing with a malignant thyroid lesion. What next? So what we need is, we need further information over and above ultrasound. We need to know the characteristic of the nodule, the relation with the thyroid surroundings, the important vital organs, great vessels. You need to understand whether there are nodes, there is any retrosternal extension, is there any involvement of the surrounding structures like trachea, esophagus. So you need more cross-sectional imaging. So you will do CT scan more commonly. MRI is not a very preferred otherwise. That will help us to evaluate the thyroid nodule, evaluation of the neck as well as evaluation of the thorax, because papillary CA will have a lung metastasis possibility. So you want further information about the extent and the spread of the disease. PET-CT not done as a routine evaluation of the thyroid, differentiated thyroid cancers, but when you are suspecting medullary CA, probably you might do to find out the distant spread. Then you do a MDT, and say for example, so what is the algorithm? I don't know, I had a talk which was so in our case, probably we decided to do a hemithyroidectomy because it was a localized disease, there was no nodal metastasis, and finally it is papillary CA classical. So follow-up and surveillance is very important. For a benign condition, you may keep patient on 6 monthly follow-up, check the size of the, when you are actually doing an active surveillance, do it 6 monthly ultrasound, just monitor the size of the nodule. If there is more than 30% increment in the size, probably you might still reinvestigate if that patient needs any further evaluation. This is one slide on active surveillance. When you know that patient has a microcarcinoma and you want to actively serve, which are the ideal candidates you would like to keep the patient on surveillance. So there are certain red flags: posteriorly located, medially located in the TO group. These nodules are not ideal for active surveillance. This is one thing that you need to understand. Anything which is in the midline or eccentric or lower pole, probably they are good candidates if you want to kind of do an active surveillance. And one small part on the incidentalomas. We don't always need to investigate incidentalomas, as sir had already discussed about incidentalomas. There are also fixed criteria and guidelines given by ADA. How do you evaluate an investigator? So more than 1.5 centimeters only you would want to investigate with ultrasonic morphological features showing some abnormality. So finally, you always begin doing a TSH, which is a baseline biochemical evaluation, which will further help you find the further roadmap. Thank you.